Good afternoon, everyone. I know you're all excited and everyone's being fed, so no one's going to be hangry. So we're starting just a few minutes late, so if you don't mind, we're going to go ahead and get this kicked off. Thank you guys for joining us. I know me and the panel are going to have a fun time here talking to you about iStent Infinite Evolution or Revolution. So thank you guys for coming. Hopefully you guys will find this entertaining. All right. So we'll go ahead and I always consider it a blessing to be able to take care of our patients and their vision, especially those with glaucoma. Now, when we think about it though, treating patients with glaucoma should be a relatively easy thing. In any disease entity, if you have two key things, usually the treatment works well. Well, in glaucoma, we have those two things. The patients are very motivated for their vision. I'm sure it's not a surprise. You've had patients in the room say, hey, doc, I'd rather die than go blind. So you have people motivated for treatment, and we have treatment options, eye drops or surgery. And it's typical. Here's the conventional pathway we use. We start patients on a drop, watch them. If it gets worse, add another drop, watch them, add another drop. If it keeps getting worse, maybe we'll sprinkle in an SLT. Then we'll do some filtration surgery, some aqueous shunts, and hopefully by the end of their life, they actually still see well. But the question is that an okay thing for us to do? The question is, what is the problem? Why are we even here? If the thought of just using drops and doing big surgery worked, we wouldn't be here, right? We wouldn't be asking the question, could we be doing it better? And I like to think that we're problem solvers. So what is the problem that we have, and what is it that we need to do? Well, the fact of the matter is the current conventional pathway that we use, what I just showed you on the slide before, using some drops, adding some more drops, and eventually rolling up our sleeves and doing big glaucoma surgery doesn't work. Here's some data from the US. About 13.5% of patients will lose vision in one eye at 20 years, and they'll eventually go blind. Eventually will go blind. That data actually gets worse in their European studies. 38% will go blind in one eye at 20 years, and 13% will go completely blind at 20 years. So although we have this treatment paradigm, it's not a great paradigm. Patients lose their vision. Now, I get some of you will say, okay, that's some people losing their vision. Well, we should never expect or accept some people losing their vision. The question is, can we be doing this better? So what's the problem with the current paradigm that we have when it comes to eye drops? Well, here are some of the issues with eye drops. You see them, but there's some things that aren't even listed on here. Patients have issues with cost of the medicines, remembering to put them in, side effects here. Really, the fact of the matter is, for the patient to get their drops in, it's almost a perfect storm. So many things have to go right every single time for the patient to get their treatment. Now, in studies, that's easy to do. We can follow them, we can encourage them, but you and I don't work in the study setting. We work in a practical setting. Patients simply don't get their drops in. Now, you may ask, how do you know? Right? No, my patients, they use their drops all the time. Well, I'm a big fan of data. What does the data show? Here's some data from the US and Europe about how confident doctors are that patients use their drops. And if you look at the ones that are very confident, it's actually a very small percentage of patients. And again, it's not like there's not a place for eye drops. The question is, can we be doing it better? And I want to challenge you guys to always ask yourself, should we be doing this better? Well, realize we're, again, gifted the privilege of taking care of patients' vision. We should always be asking ourselves, can we be doing it better? So there's an opportunity there. So this is what interventional glaucoma means to me. It's an opportunity for us to do better for our glaucoma patients. And that's really the perfect storm of there's patients that need additional care, and there's actually treatment and diagnostic options that are available. But what that requires of us, and here's where the challenge comes in, is for us to think about glaucoma in a different way. Think about it in a proactive way. Don't wait for there to be nerve damage before we respond. Don't hope and cross your fingers that adding a few more eye drops will get the patient to good functional vision at the end of their lives. We know from the data, a fair amount of them won't. And at first we can say, well, these are the options we have. We just have to deal with it. Not so much so. Now we have earlier intervention with diagnostics and therapeutics, where now it's a matter of the physician taking the responsibility on their own hands to really taking care of the patient. So this paradigm that we have of using drops and adding drops and again, hoping for the best simply doesn't work. More data points. 50% of patients discontinue drops at 6 months. Again, the way we take care of patients in the real world setting isn't the way it looks like in a study. Over 90% of patients are non-compliant to their drops. Now, I'm sure all of you agree, we would love to have more time in the office spending with our patients trying to figure out why exactly they don't get their drops in. But that's one of the barriers that we have. We don't have all that time in there. What we do know is as well-minded as our patients are, because they're scared of losing their vision, they simply don't get their drops in. So half of glaucoma patients are lost to follow-up at 1 year, and 2/3 of them never return. So that's the other challenge we have. How do we make these patients more sticky? What I mean by that is, how do we make them come back more and more? One of the biggest issues we have with patients with glaucoma, especially those with just drops, they figure after a while, every time I go in to see the doctor, although he may be a nice guy, nothing changes. Why am I going back in? I'll sort of, use my drops. I don't really notice. My vision's doing okay. It's not a problem, until they hit the point where it's uh-oh and they can't see. And then they come in, and as we know, that's going to be too late. So those that relapse more than 3 years are twice as more likely to go blind. Hopefully that's enough data for you guys to believe that the conventional way of doing things simply doesn't work. We need to be doing this in a better way. So that's where the consensus protocol comes in. Myself and a couple of other colleagues in the US came up with an idea of, how do we treat glaucoma patients? Yes, you have glaucoma patients, and we have this idea of interventional glaucoma, but what exactly does that mean? Because glaucoma is difficult to treat. You can't cookie cutter everyone's treatment. So we came up with a standardized approach that really allows us to enhance long-term patient care, but also optimize the patient experience. Because what do we always talk about in glaucoma? Yes, we perseverate on the intraocular pressure, but really what we want to do is maximize the patient's quality of life. And you can go ahead and use that QR code if you want to download the article there. It's been quite well taken in. So what does it look like? Here's a stepwise approach. Now, this isn't for every single glaucoma patient. I want to preface that with that. That funny joke of, you can ask 5 glaucoma specialists, how do you treat a patient? You'll get at least 6 different answers, right? We're not talking about everybody. We're talking about most glaucoma patients. If you divide them up based upon stratification, this is the rough approach we take. And I'm sure here in Europe, first comment I get is, we don't have procedural pharmaceuticals. I get that. Simply just eliminate that from the chart for now. And hopefully you guys can push to get that available for you. But here's a way of communicating to other ophthalmologists, communicating to your optometry colleagues, of how we can actually go about doing that. So just in a nutshell, interventional glaucoma is a proactive approach. Don't wait for there to be nerve damage. Don't keep your fingers crossed, hoping the patient will do well at the end of their life. Go do something about it. And the reason why you can is because there actually are procedures and diagnostics there that are available for you. Be open-minded. And again, remember, it's a blessing to be able to take care of our glaucoma patients, but at the same point, it is our challenge to be upfront with what's available and integrate it into the care. Thank you so much.
Thanks so much, Sev. I'm sorry I was running late at another talk, but I did want to, again, acknowledge the importance of this event. This is the European launch of the iStent Infinite, which is, I think, not even arguably, but is the most studied MIGS device ever studied in humans on the planet, which I think really builds us a big evidence toward where we're moving toward interventional glaucoma. Thank you for setting up this session on the rationale. And it's always nice to ask the why here. But let's get into the actual technology. So Kevin Gillmann, if you could walk us through the concept of bypass and now where we are with Infinite.
Okay, so hi everyone. And after this very interesting introductory talk, I'm going to talk about specifically the safety of minimally invasive glaucoma surgery, which is a subject that I think is quite relevant because we tend to take that topic sometime a little bit too much for granted. So as you remember, well, maybe not all the way from 1875, but over the last few decades, there's been a lot of innovation in the field of glaucoma. And especially since the year 2000, when we've seen the advent of the minimally invasive glaucoma surgeries. And as we know, MIGS is all about intervening potentially earlier in a much more safe environment than what we used to do with traditional filtering surgery. And mirroring this whole array of new technology, we've seen a lot of data coming in the same time, especially since 2010, when we've seen a lot of new publication from all these different groups and techniques. But the iStent Injector remains the most studied MIGS device out there, with nearly 400 publications to date. So one of the big things that have been changing over the last few years is that big demarcation between MIGS and MIBS, because we've just realized that, well, you can't really be truly minimally invasive while you're creating a filtration bleb in the same time. So it's been very important to separate those two entities just to clarify the expectation and the definition of the different type of techniques and approach. So here today, I'm really only talking about the MIGS side of these groups. And if you've been following up all the recent publication and reviews coming out about MIGS, something that you'll find quite striking is that in all these publications, you've got very varied, very wide difference in terms of percentage of IOP changes after surgery. But again, what's very striking is if you look at the final outcome, the IOP at the last follow-up, even though there is some variation, they all tend to come to pretty comparable outcomes with always IOP within the teens. And that's something that's quite striking there is no matter how many studies we see. Yes, sure. Yeah, no matter how many studies come out, we keep seeing that there's variation in results in terms of efficacy always around the mid-teens. And as you've just heard, there's been that big change in paradigm where we've seen a lot more interventional glaucoma, as in we are more happy to offer surgery and intervention in patients who are otherwise quite fit and healthy and pretty early in the course of their diseases. And who are also patients who've got many, many more years to live after they have the surgery. And that is placing an even greater responsibility upon us to offer surgery and techniques that are even more exceptionally safe, because those patients we operate on are otherwise doing pretty well. And as I said, will live many years after the operations. So that's why I've produced with a group of very outstanding colleagues, I'm very grateful to, by the way, who are all listed up here, a recent review of all the data we could find on the main MIGS topic, on the main MIGS techniques over the last 10 years, which covers over 400 articles and nearly 70,000 years of observation. And I won't bore you with all the details about the methodology of the study. You will see that in the paper when it comes out because it's been recently submitted. But okay. But what you can see here is just a few results from that study where we've basically separated it between different groups of technique based on the mode of action. And something quite interesting there is what we could identify were essentially 3 different types of complication. One of them being the very common type of complications, all these transient IOP, self-limited IOP spikes that can be clinically relevant, are worth knowing, that are very common and common to most type of MIGS, regardless of the nature. We've got a second type of complication that we identified, which were the device-specific complication that are specific to a set technique and sometimes unique to that technique. For example, here for the ab-interno canaloplasty, you've seen a Descemet detachment that in some studies can be quite high, in up to 9.1% of patients. And you've got one last category of complication, which were the more chronic type of complication, the one that can yield long-term effect for a patient. For example, here, macular edema. So if we're moving to a different type of MIGS, here we've got mini-eject, where we find the usual IFEMA, IOP spikes. But what we see is a slightly different pattern with more hypotony. In terms of device-specific complication, we see more choroidal detachment, which again mirrors the rates of hypotony, pupillary changes, which is related to the more traumatic nature of the procedure, and some device misplacement, which in the case of the mini-eject was sometimes related to movement of the stent afterwards, and that sometimes needed to be extracted and replaced. In terms of trabeculotomy, we see the usual with IFEMA and IOP spikes, but here we can see a higher rate of IFEMA that were persistent and sometimes requiring washout. And what's quite interesting there is there are some wide variations in terms of trabeculotomy techniques. And what we identified is that if you try to be more tissue sparing in the technique that you use, you had less of these risks of persistent IFEMA and IOP spikes. In terms of specific complication, quite interestingly, some studies looked very specifically at for peripheral anterior synechia and supraciliary effusion. And whenever you started looking at those complications, you would find them in quite a large proportion of patients. And that's another very interesting point. Sometimes some complication can be underreported because they're just not looked for. Now moving to the iris, same usual transient ifema and IOP spikes, but we also see some specific complication, which again are the gradual formation of peripheral anterior synechia and loss of endothelial cell density. I'll come back to that later. And finally, for the iStent inject, again, same usuals, but also the most specific complication was mispositioned device. That rate up there at 44.9% was from one of my publications where we specifically looked at the position of the iStent. And what's quite interesting there is that ever since there's been an upgrade in the design of the iStent with the iStent W coming out and with better surgical training from the surgeons and the iStent W with a larger flange, we've seen a lot less of this misposition of the iStent. Here, again, that will be out in the final paper, but just really to give you an overview, that's summarizing all the complications for all the different type of procedure. And I said I would come back onto the question of endothelial cell safety. And that's an extract from a very, very interesting paper from our colleague Ike Ahmed. That's looking specifically at endothelial cell loss following iStent and iris surgery and comparing it to phaco control. And what you can see there is that in the bottom curve, that's the endothelial cell loss following iris plus phaco compared to the top one with phaco only. And you can see that there is a difference at 3 months, but it's not statistically significant. But as time goes by, the difference between the two curves widens and it becomes statistically significant. In comparison here, you can see in the very, very tiny corner there that the two curves corresponding the iStent and the phaco control, and you can barely tell the two lines apart because they overlap. So here, no difference in the iStent. So as a conclusion, I would just say two things. The main outcome of that review was the fact that we really need better harmonization in terms of data reporting for the safety of MIGS, because there were very, very wide variation in the way complication and adverse event were looked for and looked at in the different studies and the way they were reported as well. So it's very important that we get better data on this. Regarding the devices themselves, one important point is that any type of MIGS surgery has complication, even if they're not that clinically relevant, it's always important to bear that in mind and to tell our patients. But in terms of device, what we found was that the iStent and the ABIC were the most favorable, at the most favorable safety profile in that review, that the ABIC in the literature was a little bit conflicting because of the varying rate of macular edema and Descemet membrane detachment, which we don't always know if it's surgeon-related, technique-related, or method-related. In terms of iStents, well, the main long-term complication was just the misposition of some device, which we have not identified as being related to any risk for the health of the patient, but essentially related to a bit less efficacy in the use of that technique. And as I've just said, the main outcome of this is that we really need more standardization in future studies on MIGS. There we go. Thank you for your attention.
Thank you, Kevin. That was a very great review of where we are with MIGS and differentiating various MIGS. And I think the safety part of it is when we first had the definition of MIGS, I mean, the safety was the first paramount parameter. So I'm glad you focused on that as well. All right, Imran is up to bat. He will talk about next generator injector systems with the Infinite.
So it's a pleasure to be here as part of the
Imran, could you put your
iStent Infinite launch, and being one of the first surgeons to implant the Infinite, I'm going to share my experience. So, so what's the difference between the two injectors? In terms of superficially, the injectors look fairly similar, but we're going to drill down into the details to sort of look at why the Infinite really is a step up in terms of efficacy and also in terms of efficiency and predictability, importantly, of surgery. So we start off with the stent delivery button. One of the key features of this button is that it allows you to repeatedly attempt to put the stent in. So that's one of the reasons it's called the iStent Infinite, because you've got an infinite number of clicks. Hopefully you won't need that many otherwise the patient will be lying on your operating table for a long time. But that's one advance. You've got the singulator, which is a little bit like when you're reloading a gun. When you're reloading the stent for the next implant, you ratchet the singulator back to prepare the stent for optimal deployment. You've got this 8-degree angled insertion tube, and I think this is really useful and helpful. And certainly in my first few cases, what I've found is that having this angulation actually allows you to approach the trabecular meshwork in this sort of en face perpendicular view, sort of approach that you need to get that stent in the right place within the canal. And then you've got this introducer tip, and then what the introducer tip does is it sort of sits against the wound, and the trocar actually passes down the tube and enters the anterior segment. And the advantage of having this sort of introducer tip is that it almost seals your wound somewhat, and therefore you're less likely to lose viscoelastic during the implantation process, and that helps to maintain a firm anterior chamber. And I think the other thing is this protects against inadvertent injury to the cornea and the iris. And then you've got the proprietary 3 stents that are very similar to the iStent Inject W, but obviously you've got 3 stents now, so you can access more of the distal outflow system. So one of the differences in terms of trocar visibility, so this is a current iStent Inject W, and when the bridge was placed over the trocar, it did impede visibility of the actual trocar system, and therefore by removing this, you can have this sort of a view down the trocar, almost like a snooker cue, so you know exactly where you are in terms of implanting accurately within Schlemm's canal. And as Kevin alluded to, one of the issues with iStent has been previously is malposition, and I think certainly with this sort of device now, malposition should be very, very uncommon, and you should be able to do a more predictable procedure. And with the 3 stents, you've got this ability to implant over a greater area of Schlemm's canal. And so what I tend to do, or what we're taught to do, is to go straight across from the wound first and implant your first stent straight across, and then move to the left to do the second one, and then come out of the eye so that you get that bigger angle between the sort of first and the third stent, and that helps to do that. So we're going to just look at some of my cases. So these are the first 3 cases that I've done, and it will show you some of the learning curves as well. So going up, this is a patient on 3 meds, pressure of around 30, so real pressure. And we're going in with the device now, and I haven't followed the instructions with the first one, so I've gone over to the left when I shouldn't have done. But anyway, we go with the first stent, and that stent, from my perspective, was not quite implanted correctly. There was a little bit of the stent is under the TM, so we're going to come back and address that in a minute. This is the second stent going in, and that goes in very well. So it took me 1 stent to master the implantation technique. And then we move across to the right side, and that's the third stent going in. And then we're going to use the Helon cannula just to tap the stent. So I like to do this because it helps me just to judge that the body of the stent is in Schlemm's. Now there, I've popped it out, I've popped it back in. And then I like to do this thing called decompression gonioscopy. So we really decompress the eye, and this really allows us to see reflux, and I'll show you that in the next case. But here you can see temporally nasally beautiful reflux and blanching of the outflow system. Case 2, this is a high myope, pressure 25 on 4 classes of medication, undergoing cataract surgery. So this is the first stent going in straight across from the wound, and that stent goes in very well, and we're happy with the position there. We go across to the left for the second stent, and once again, well positioned, so happy with both of those. And then this is the third stent, and you can see that with the trocar is very, very nicely visible with this particular system. And then again, we're going to do the decompression gonioscopy test, and you can see that as we decompress, we get really nice reflux through the snorkel on at least a couple of stents. In this case, and these patients have had early on and have had very good outcomes. So this is my third case. This is again the first stent, very similar, and then we go across to the left again and implant the second one, and then once again to the right for the final stent. And on this occasion, when we do the decompression gonioscopy, we can see that through all three stents, we eventually see blood refluxing, and we call this it used to be called the double waterfall sign. We now call this the triple waterfall sign. So there you go. You got three stents positioned very well. So I think this has been, from my perspective, a real advance in the way that we do this surgery. It's critically important because of the issues around positioning, that the device enables us to place the stent in a very predictable and precise manner. And I think this current sort of device now allows us to do this much more repeatably. Thank you very much.
Thank you so much, Imran. And I do want to, again, encourage the audience to use their app. There's an app you can use and to ask questions. So we'd love to get some interaction and questions. We'll have some time after our talks. We've got Henny Beckers to lead us with some evidence on what Imran just showed with the Infinite. And we have a couple of really important papers that she'll be sharing on others as well. Thank you.
Thank you very much for the introduction. And yes, of course, there's not so much evidence on the Infinite yet because it's just coming to the market. But the iStent Infinite, the idea behind it is that it's more relevant for treating patients with more advanced, moderate to advanced glaucoma when regarded compared to the iStent Injector that we had earlier. And if you see this as this slide, we had this pivotal study by Samuelson in 2019 on the iStent Inject. And you see that the visual field MD was about 3.4 MD. Well, in this new study that I want to present today by Sarkisian, which is the pivotal study on the Infinite, you see the visual field MD is minus 14.4. So that's a huge difference here. So I'm really interested to know if this new device can treat more advanced glaucoma. So I want to take you to this first interesting study. And the inclusion criterion was uncontrolled open-angle glaucoma and a medicated IOP of 20 to 35 millimeters of mercury. There was no washout on medication in this study, but there were two important groups addressed in this study. And the first one was patients with failed earlier glaucoma surgery. They had at least one failed filtration or cycloablative surgery, and they were back on more than 2 medications. And the other group that was included in this study was patients on maximal tolerated medical therapy, and they failed on more than 4 medications, so they had really advanced glaucoma as well. Exclusion criteria of this study were prior organ laser trabeculoplasty, because that can be leading to a compromised TM, prior glaucoma or intraocular surgery at the last 90 days, elevated episcleral venous pressure, and otherwise secondary glaucoma. Safety parameters that were addressed in the study were adverse events like inflammation, IOP increase, further glaucoma surgery, severe visual field loss or glaucoma progression, and stent-related procedures like obstruction and other things that might happen. Things that were also recorded were best corrected visual acuity, visual field fundus aspect, and slit lamp biomicroscopy. The effectiveness endpoint was 20% or more lowering of IOP, minor IOP, on fewer medications from baseline without significant safety findings or without any further adverse events. And the second endpoint was reduction in mean diurnal IOP in millimeters of mercury from baseline. And if you look at the patient characteristics in this table 1, you see that there's a big difference between the study population of the failed surgery group and the medication group. Way more patients in the failed surgery subgroup, which I think makes this a very interesting study. And if you look at the visual parameters here in the table 2, you see that especially in the failed surgery subgroup, there were more patients included with severe or advanced glaucoma. And if you look then at the endpoints at month 12, and we see the proportion of eyes responding with a clinical meaningful mean diurnal IOP reduction at least 20%. We see very good results in both groups with an overall percentage of success of 76%. And we should expect a better percentage, of course, in the medical group. But I was really surprised to see that the failed surgery group could get this good results with 73.4% having success. And similar findings you see in this change of IOP from baseline with the medical group lowering more than 8 millimeters of mercury, but also in the failed surgery subgroup more than 5, which I think is a good result. And the final slide on this study is patients who had success with IOP lower, at least 15 millimeters of mercury, and 18. And you see there, I think that's quite stunning. 31% of patients in the failed surgery subgroup reach IOPs of 15 and lower. And I think that's an improvement from what we have seen before. And 18, of course, you have seen even better results. So this is a very crowded slide. I'm sorry to give you this, but it's just meant to show that the numbers that you see here in adverse events are very low. They're just 0 to 2. So this again demonstrates also with the Infinite that this iStent is very, very safe, minimally invasive procedure. So what about the safety in this trial? You really saw exceptional intraoperative and postoperative safety, demonstrated along the patients with especially the failed surgeries. We saw no hypertony, no explants, no cyclodialysis clefts, and no device-related interventions were needed. Only 3 eyes required secondary and surgical intervention following this Infinite procedure. The second good study that I would like to present to you is a study done by Ike and his colleagues, and it was a 6-month follow-up study comparing the Infinite directly versus the Hydrus in the standalone procedure. So I forgot to mention the first study was also a standalone procedure. And in this study, during 6 months, also uncontrolled patients with open-angle glaucoma were included. But the difference in this study is that patients were washed out from their medication. So patients that were included had an unmedicated mean diurnal IOP of at least 21 millimeter of mercury and less than 36 millimeter of mercury, which is usually a safety precaution following the medication washout. They had to have open angles, of course, and a corrected visual acuity that was still reasonable. There were no criteria on glaucoma disease severity in this study. Exclusion criteria, again, prior ALT, which of course can lead to compromised TM, prior glaucoma surgery or intraocular surgery within 19 days, elevated episcleral venous pressure, and secondary other glaucomas, and lastly, chronic ocular inflammation. And if you look at the patient characteristics in this study, you see that the groups of the iStent Infinite and Hydrus were quite comparable. But if you look at the visual fields, and you see quite a good demonstration about around mild, moderate, and severe cases. So all kinds of glaucoma patients were included in this study. And then we look at the effectiveness endpoints at month 6. And of course, the most interesting of this is the second graph here, which demonstrates the proportion of eyes with no surgical complication and achieving unmedicated mean diurnal IOP reduction from baseline of at least 20%. And then you see a statistically different outcome between the iStent Infinite and the Hydrus group with a 13.2% of difference, which is really statistically interesting and significant. And the same applies if you look at the mean IOP change. Here again, the first graph is less interesting because this is with medication. But the second graph, it shows the change from baseline in unmedicated mean diurnal IOP in eyes with no surgical complication at month 6. And then you see a small but significant difference between both groups, with the iStent Infinite outperforming the Hydrus. If you then lastly look at the mean diurnal IOP at month 6, and we compared IOP categories of less than 21, less than 18, or less than 15, then we see that, of course, at 21, the results are better in both groups, but still the iStent outperforms the Hydrus. And as we look at the less than 15, then 35% of patients get IOPs less or more, 15 or less in the Infinite group, which is essentially more than the Hydrus group. And the same applies if you look at the percentage of IOP lowering as is shown in the second graph. And you can get up to 40% lowering in more than 20% of patients in both groups, but still the iStent Infinite performs better. And if you go back to higher IOP categories, then even the differences are bigger. So adverse events. In both groups, they were quite mild, but if we look at the difference between both groups, we see more complications in the Hydrus group, mostly due to improper anatomical placement, because it's a little bit more difficult to get a Hydrus properly in place. And the second is the peripheral anterior synechia, which is also more easily to happen in a Hydrus placement. Conclusions of these studies were that based on the IOP lowering medication washout and surgical complications that happened or not, a higher success rate in the iStent Infinite group was found when compared to the Hydrus stent group, with a statistically significant superior unmedicated IOP lowering in the iStent Infinite group, fewer adverse events, and more surgical complications in the Hydrus group. And this may be related, at least for a large portion, to the differences in sight, as the Hydrus is a bigger device and it takes a longer learning curve to get it in properly. And so this difference might be according to the device properties. But it shows that in this study with 6 months, the iStent Infinite outperformed the Hydrus stent when considering both effectiveness and surgical complications. So I'm really interested in long-term results with the Infinite, but I think we have got a very promising new device here. Thank you very much.
Thank you so much, Henny. Well, my job is to finish this off, and we have some time for questions. And we actually have some good questions that are going to be asked. So our speakers are going to be on their toes because there's some tough questions for you guys, so watch out. All right, well, listen, the group has done a great job already with talking about this, and just a few observations about MIGS, which I think has really, been the first sort of foray into thinking about intervening early. SLT be another one as well, where we've kind of now developed many products, and we're deciding when do we cut, when do we dilate, when do we stent, when do we combine. Kevin had a nice overview on the different options and the strengths and weaknesses of those. We've gone from an era basically where we're targeting devices perhaps to more broader placement of devices with multiple implants that you've seen here. And in many ways with outflow, it's about access. It's access to collectors. And I think, the 3 stent data, but whether it's preclinical data, basic science, or whether it's clinical data, seems to support greater efficacy. Obviously, combined phaco has been an area that in North America has been a very predominant area of development. I think in the rest of the world, I think we're still catching up a bit. A lot of patients who have congenital glaucoma are still probably not being considered for combined MIGS, which I think is something that hopefully is a message that is resonating here at ESCRS. And if anything, the clinical world has made us go back to the lab and understand how these procedures work best and how to best use them in clinical practice. Now, we've already gone through all the different options available. I think it is a confusing time. And I want to just say that, when we first thought about MIGS as the differentiation from glaucoma surgery traditionally approached, one of the key elements was safety, especially when we're combining with phaco. And I think that, as we've heard, we can debate efficacy a lot, but safety-wise, using microstents in the trabecular meshwork has been shown over time to have, the safest approach, minimizing tissue trauma and hyphema. We've seen the evolution of iStent, and we've seen the evidence build up with this, which has been great. And I think the theory behind multiple stents, and we were doing this even with the first generation stent, and publishing this data showing the benefit of having access to a greater amount. So, the goal here is to establish safety, which a single stent showed. And as we go from 2 to 3, we're now trying to tap into more and get more out of these stents while still retaining the value of safety, while enhancing the efficiency and predictability of delivery. And we've seen some nice results. Well, this is a patient I'm going to show you. This is a pseudophakic patient. You can tell because of the capsular fibrosis. And although most of the procedures are done with combined procedures, and I'm going to show a procedure that I use, a double mirror lens. This is some extra advertising, although I'll make no money on it. And you can see the double mirror, we can do this without tilting the microscope, without tilting the patient's head, which is a barrier for many who do a lot of cataract surgery. And the view, we could argue, is reasonably similar to what we get with a prism. There we see the injector through the incision. Imran nicely showed about the injector. And what I'm going to push people to do is try to get beyond just placing the stents within what we can see in one view. That's the benefit of having a mirror that you can rotate as well. The goal here is to access. We know that one stent, if you watched dye videos, can access at least 2 clock hours of aqueous outflow. So it makes sense to get them far apart, 2-3 clock hours if you can push the limits. And that means we have to be, really kind of tilting our microscope and our head and our chair to get the right angulation. Now, I still do implantation from left to right. I think it's reasonable to do what the convention is, to go straight ahead. So, Imran, I think you're on the right track at the beginning, man. You can go back to that if you want. I don't know. I think there's either way you can do. But one point as well is aim for the top of the TM, because we have a negative angulation as we're entering, sloping into the angle from the cornea. And this allows us to make sure we get the stent into the canal not too deep. That's one of the common mistakes. And the other problem sometimes, the challenge is, how much do we press against the angle? If we're too light, we under-implant. If we're too heavy, sometimes we over-implant. And as Kevin said, the W, which is a larger flange, prevents over-implantation. So we can be willing to push a little bit. I suggest you push so you get a little indentation. I call it a little bit of a U pattern. You don't want a V pattern, not a V, but a U. Just a gentle slope. We're aiming there nice and controlled. You got a good view. Release, and when we release, we want to pull back, straight back, ideally, so we don't knock off the stent. And there we see the placement present there. We now are going to swing over quite a bit to get a few clock hours away. And again, go top of the TM, the gentle depression, and don't release until we're sure the trocar is not biased. It's not twisted or turned inside that cannula to prevent that bias, which is important. You can see the stabilization of the anterior chamber. Why is the chamber so stable? It's because of the ability to retain the viscoelastic. The incision is kept nicely opposed with that retractable sleeve. And then we're going to rotate again, my left hand finger rotating around. We want to really get over. I'm going to really stretch this. And you can see that I'm placing these implants quite far apart, maybe more than what you're used to seeing with the Infinite. And I think that allows us to push the limits to get broader access to the canal. Now, when you're starting, I think it's quite reasonable to place the stents a bit closer. You want to get them in, which is quite reasonable. But as we get a bit more proficient, I'm going to push us all to maybe get these stents placing wider apart. And some people, and we've even placed one of them even temporal by making a supranasal incision. There's some evidence that maybe that might be helpful for that. So I'm just going to present just a little bit of data. This is real world. It's quite heterogeneous data from my fellow that presented this. We wanted to really see what the results were combined phaco with Infinite. Now, this is not a control study. There's no comparative group here. And we use an endpoint that I think is reasonable to use with MIGS, which is proportionality. Proportion in patients that were on medication reduction and no increase in pressure, or 20% reduction with the same or less medications. And if you had surgery, then you failed. So that's taken out of the success rate, which I think is the way to manage this and following these patients. This is quite a varied group, a lot of different glaucomas, pseudosfoliation, even some off-label, diagnosis. You can see the level of disease. My practice is a bit more advanced, and we did use them in many advanced cases for medication reduction, not necessarily for driving pressures low. You can see the pressure pre-op and the medication load present there. And just to see the IOP results, 15.9 to 13.4 and 1.7 down to 0.8. So we do see a substantial reduction in IOP medication, which is nice to see. And again, I would argue to say that this is more than we would expect to get with phaco alone, although again, no control group as well. We had about 87% of patients who had primary success at 1 year, which is what we want to see. Success rate, at least over 60, 70% would be the minimal clinically important difference. And some of the patients who did not reach that either had an unchanged pressure or medication reduction was not as much as we would anticipate for success rate. But no one had an increase in their pressure or increase in medication. So, our real world results was retained the safety of what we expect from iStent. We were happy to see, the IP efficacy. There's some patients who may get a pressure elevation in the first month, maybe steroid, and they were managed quite well. So, as we kind of finish off here, and again, we're going to get some questions here. We have a few minutes. I want to emphasize again, and Sev talked about this. I may ask him a question on this as well, but, earlier intervention, why is earlier intervention good? And Sev mentioned the many reasons why, and I'll mention one more reason. Because earlier intervention like MIGS or even SLT works better when we do it earlier in disease. So think about that, right? Choose a procedure that works best at the right patient's journey in their lifetime. If you leave a procedure like MIGS till later on in disease, when the disease is more fibrotic, more irreversible, more secondary changes in the outflow system, and more optic nerve disease, they don't work as well. And that's proven with SLT and also proven with MIGS as well. So think about doing it earlier. Obviously, the first place of entry is combined phaco. I'm of the belief that anybody who has astigmatism should be offered a toric lens. Not everyone does or will use an implant, but at least we offer it. And same thing with the MIGS procedure. We should at least consider it. Not for everybody, but for patients who have glaucoma, it's a consideration. I know standalone MIGS is a very small area of the market right now, globally, especially outside North America, but we are doing more standalone. And the Infinite, of course, in the US, as we've seen on 2 studies. And I want to mention, although we have just only 2 studies on Infinite, they're 2 of the highest quality evidence studies. And one of the problems with MIGS is we see a lot of studies, but a lot of poor quality studies. And unfortunately, we sometimes make these decisions on poor quality. I want to emphasize how valuable it is to get prospective, controlled data, randomized data. And so measure the balance between effort, risk, and cost and efficacy as you do these procedures. Think about the tissue trauma that may occur when we do these procedures. And again, we need to build more evidence. So thank you very much for the discussion. I want to get to some questions, though, as we move along. And Seb, maybe the first point to you is, interventional glaucoma as a mindset seems like a good idea, but practically speaking, how would you say would be the best measure of someone who says, listen, I think I need to develop this mindset? What are the outcomes to measure in terms of how you would think that, hey, you know what, I'm actually doing something that is more interventional, changing the way we practice?
Yeah, I think that's a good question. A lot of us, I think we are interventional, but there's always areas of opportunity of how to get things better, right? And I get it. Anytime you're doing something new and different, it's difficult because you're doing something new on real patients. Really, what I would ask you to do is just ask yourself, for each individual patient, what do I think is right for this patient? As if they were my mom or my dad. And by the way, I like my mom and dad, but what's the right thing to do with them? And I think you'll realize that there's a lot of opportunity out there to at least offer it to patients. And I'm not telling you to force it on a patient, but at least offer it to them. And, one of the interesting points here, as these technologies come out and there's more and more evidence, especially sound evidence that, as Ike was mentioning, people are going to get frustrated if you did not offer the opportunity for when you do this. So let's say, for instance, some of the processes we have that are approved for with cataract surgery alone, if you didn't offer it to the patient, and let's say the patient doesn't do well with their glaucoma later on, they can look back and say, wait, this was available and there was evidence for it. Well, doctor, why didn't we do it? So it's really something you need to go out there and think about what's right for the patient. Remember, you're the guardian of their vision and do what's best in their interest. And don't wait too long to do things. I agree. The earlier you intervene, the better your outcomes will be.
Thank you. Okay, we're going to try to get through these questions as fast as we can. So this next question, it could be for Kevin or for Imran. And there's kind of 2 combined questions. When you're first starting to do MIGS, what would be the first choice you would use in terms of doing MIGS as the first foray into MIGS? And also with the Infinite now, how would this replace GAT is the question basically. Would it allow us to do maybe a different subset of patients? So maybe the first question and the second question. Go ahead, Imran. Just the mic.
Okay, to answer the first question, I think that when you start off doing MIGS, you really got to go for the
procedure with the highest safety profile. So when people ask me what's the first procedure to go with, I always say the iStent, because I think you're not going to cause any harm. And as physicians and doctors, first do no harm, right? So I think it's important to consider safety when you're first starting this sort of surgery. In terms of the second question about the relative merits of the iStent Infinite versus GAT, I think that in my practice, I tend to use GAT in a certain cohort of patients. So patients who, for example, have very high pressure, steroid-induced glaucoma, juvenile glaucoma. And I would tend to use the iStent in patients who perhaps have lower pressures. So I don't think this will necessarily replace GAT, in my view. I think there are some patients who do very well with GAT, and I would continue to use GAT in those. But I think certainly we're seeing the data here that more advanced patients would do very well with the iStent Infinite.
Okay, there's a number of questions more on technical challenges. You know, in the event of malposition or under-implanted stenting, you know, what's your approach? Do you fix it at that time? Do you reposition it? Do you wait till after you put the first ones in?
So I think with malposition, the key thing, and this is you need to learn this in the dry lab setting as well, it's how to rethread the stent, a floating stent in the anterior chamber. I think one of the things that creates malposition is a poor view. And with certainly with the Infinite, I tend to use a little bit more GB than perhaps I would have used with the G1. That just maintains your anterior chamber better. But in terms of repositioning, I think that the key is to implant the stents that are already on your device, and then go back to the stent that you've misplanted or you've left hanging in the anterior chamber. And the key thing with the Infinite now is you have multiple attempts to be able to implant that, and the force of each delivery, each click is about the same as compared to the previous device.
Yeah, and you have to kind of stick hand a little bit to get it, you know, oriented so you have the back in front of you, and then rethreading it, maybe gentle apposition against the angle to get it to rethread. Okay, there's also some questions here about the right patient profile for the different iStent families. You know, if one has access, Kevin, to both the W and the Infinite, when would you use one or the other?
Well, I think that first comes down to availability, depending on what's available in your country and where you work. And beyond that, we've seen that the device itself is very similar between the iStent W and the one you inject in the Infinity. The main difference being the number of stents you implant in the Infinity. If I've got the choice between the two, and if I could go for either of the two, since there doesn't seem to be any difference in terms of safety profile, I would just go for the Infinity in any case.
And any you know, reflections on? I mean, you showed a lot of standalone data. You know, do you have any standalone experience, or is that still sort of an area that we have to explore more? Is there a role for MIGS and standalone?
Yeah, I would like to explore that. I think the evidence shows that there might be a bigger portion doing it really well for patients with standalone surgery. And I think this device might deliver on that because of its simplicity, the easy implant, well, I think this fabulous first data.
Okay, great. Well, I want to thank the speakers for all. You know, we had to start a bit late with a huge line coming up, and one guy was late. But everyone did a fantastic job, and I think we want to thank Glaukos. I mean, Glaukos has really led the charge with, you know, this whole different mindset and with technology. I want to again emphasize the need to train. I think training is important. Evidence buildup is important, and you know, keep on pushing forward. So thank you so much, everybody, and enjoy the rest of the meeting. Thank you so much.
Adopting an interventional mindset is critical to taking great care of our patients. The fact of the matter is we have patients that are highly motivated to get their disease under control because fear of losing vision. And in theory, we have options to treat it. But when you look at it in practical terms, it simply doesn't get done. So we're looking for other ways to better take care of our glaucoma patients. Interventional glaucoma does that. And it does so by providing a proactive care, not just diagnostically, but with therapies to allow us to improve our patients' quality of life as much as we can. I think the most important reason why patients look for an IG approach is because they're fed up with their eye drops. In theory, it's easy. Yeah, just use these drops every single day. But our patients run into barriers. These barriers include cost of the medicines, side effects, remembering them, putting them in. So unless the patient is really able to get a perfect storm, as I like to say, able to get all of those barriers addressed, they simply don't get their drops in. So after a while, as motivated as our patients are to take care of their glaucoma, they simply can't get their drops in, so they look for alternative ways. Interventional glaucoma allows that. I think today's iStent Infinite talks went really well. There's a couple of key takeaways to take, and I think Dr. Ahmed put it best. Whenever we're trying to incorporate interventional procedures like iStent Infinite, doing things earlier generally allows us to get even better results. So as scary as it is for physicians to adopt newer technologies, we typically hold them for our patients where we've tried everything else out. Really, these procedures work better earlier. And I think the more you try it, the more comfortable you get. The earlier you use it, the better your patients will be. The way iStent Infinite fits into my practice is for patients who've had cataract surgery already. I primarily like to use it as a standalone therapy with goals of either, number one, decreasing the eye drop load for our patients, as we discussed before, still keeping the pressure the same, or having patients that are still on the same number of eye drops, but reducing the pressure because the goals need to be lower. iStent Infinite fits through a broad class of speculum of where you can use it, all the way from earlier to later in disease. And that's one of the beauties of the product. You can use it in combination with other procedures like cataract surgery, or you can use it as a standalone as well too. So really it's a matter of what's best for the patient at that moment. The doctor's left to pick and choose. I think the biggest things that I've seen with my patients using iStent Infinite was how happy they are when we're able to reduce the number of drops going in. Patients simply don't like getting their eye drops. It's either not affordable, or they cause a lot of side effects, or they have a hard time remembering them. They want another alternative to care where it doesn't require them having to put drops in, which is where interventional glaucoma does really well.
I think this Glaukos Symposium today was really exciting. Lots of interesting data, lots of interesting tips as to how to implant the device. And in terms of my practice, I've started using it already. I was the first surgeon in Europe to use the iStent Infinite, so I showed my first 3 cases today at the meeting, and I've started using it in my practice. So for me, I think it's one of the first go-to options for me. The reason for that is that it's extremely safe. In my hands, certainly it's predictable, and patients get good outcomes. So certainly when it comes to intervening in Schlemm's canal, I think there is good evidence now. Kevin presented a meta-analysis today of some of the safety data around MIGS. And I think really the safety is now the key factor in deciding what MIGS procedure to do. And so for me, the iStent Infinite has by far the highest degree of safety compared to all of the other MIGS procedures. And therefore, in certain patients, I would say it is my go-to option. And so I think safety really is the key now in terms of deciding which MIGS procedure you should be doing on patients. So I think with the iStent Inject W, obviously the first thing is that there's only 2 stents on there. So we know that putting 3 stents in will allow us to tap into more of the collector channel system and the outflow. So that's the first difference. The second is that you have an infinite number of clicks on the button and the injector system. This is especially useful for those surgeons who are in the early part of their learning curve and they have misimplanted a stent, and they can retrieve the stent and use those clicks to reimplant properly. The other one is that there is a 8-degree angle between the injector, the body, and the actual delivery trocar, which also helps in terms of implanting the stent accurately, because it gives you a higher likelihood of you approaching the trabecular meshwork at a 90-degree angle. So I think those are sort of main ones, I would say. I would say that it's definitely a good choice of MIGS device. It's a very safe device. And from the point of view of a surgeon who's learning how to do MIGS, you don't want to create any problems and you don't want to create harm for the patient. So based on the data we have so far, it seems to suggest the iStent is the safest, and therefore I would definitely say that should be your first choice in terms of trying to learn MIGS procedures, and good luck.